Okay, well, I guess I will just get started here. I'm Allison Harkin. I teach in disability studies, gender and women's studies, and English here at the university. And I'm going to start my talk today in a way that may seem a little bit odd, at least for a paper that focuses on dominant American narratives concerning attitudes toward health and illness, and how people are expected to react to their own health and illnesses. I'm going to read some snippets from a few obituaries I found during a 5-minute web search. And I don't know about you, but I find obituaries both interesting and moving. Often they reveal such love from family and friends for the person who's died, and many describe the interests and characteristics of the person. But on the other hand, certain conventional words and phrases often emerge and demonstrate prevalent attitudes. And I think you'll recognize at least one of these conventions as I read. When diagnosed with breast cancer, she remained dedicated in her work and in her will to fight her illness. She remained a brave, iron-willed woman even throughout her final months. To be sure, if pancreatic cancer was a cancer that could be beat, his fight would have clobbered it. He passed away March 6, 2017 at home, surrounded by his loving family, following a courageous battle with cancer. And another one. He passed away peacefully on Monday, March 27, 2017, after a 9-month battle with pancreatic cancer. And then one more. She passed away peacefully on March 2, 2017 in New York after a long and courageous battle against cancer. Now, I'm not criticizing in any way the families who wrote those obituaries. I think many of us may be comforted to think our family member wanted to remain with us and therefore fought hard to do that. However, in addition to whatever individual motivations may be present, there's a societal convention at work here. Those with cancer or life-threatening illnesses are expected to battle them and demonstrate a positive attitude. I'm sure we've all heard comments about the power of positive thinking when someone we know has received a diagnosis of cancer. The ostensible reason is that a positive attitude will assist with healing, but often really such an expectation allows others to assign responsibility for outcomes to the individual. Audre Lorde, the feminist author, for example, wrote in her wonderful book, The Cancer Journals, about the kind of individual responsibility that was placed on her during treatment for her breast cancer, which meant that she was expected to make others feel comfortable and keep an unfailingly positive attitude while keeping her pain and fear hidden. Something that I should mention people with disabilities also are routinely expected to do in the presence of non-disabled people. Lorde describes, for instance, a visit from an American Cancer Society volunteer shortly after her mastectomy. Quote, "The woman from Reach for Recovery who came to see me in the hospital, while quite admirable and even impressive in her own right, certainly did not speak to my experience nor my concerns. As a 44-year-old Black lesbian feminist, I knew there were very few role models around for me in this situation, but my primary concerns 2 days after mastectomy were hardly about what man I could capture in the future, whether or not my old boyfriend would still find me attractive enough, and even less about whether my 2 children would be embarrassed by me around their friends. My concerns were about my chances for survival, the effects of a possibly shortened life upon my work and my priorities. My concerns were quite different from those spoken to by the Reach for Recovery volunteer, but not one bit less crucial nor less poignant. Yet every attempt I made to examine or question the possibility of a real integration of this experience into the totality of my life and my loving and my work was ignored by this woman or uneasily glossed over by her as not looking on the bright side of things. I felt outraged and insulted, and weak as I was, this left me feeling even more isolated than before." End of quote. Other writers, including the blogger Jeannie Sather, who was an advocate for more patient control over cancer treatment and decision-making, have criticized the battle metaphor for another reason. In her soapbox number 3, The Language of Cancer, she wrote, "Let's start with the cliches. Died after a long and courageous battle with cancer. Everyone who dies of cancer is automatically brave. Read the obituaries, you'll see what I mean. Notice all the military metaphors and male imagery? Why is that? It's gotten so that I'm afraid to be a coward. It might show up in my obituary. Jeannie Sather died Wednesday after a brief cowardly skirmish with cancer." So both Lord and Sather, in their different ways, are questioning and resisting as exclusionary and harmful this dominant way of describing the illness experience, which left both of them feeling silenced, as if the truth of their stories and experiences was denied. In addition, a perception that a person's body is a battleground and illnesses are enemies to be fought at any cost assumes egalitarian access to medical options and effective care, which are still inaccessible to many groups of people in American society, although the Affordable Care Act certainly made them more accessible. Similarly, flattening narratives about individual responsibility for health are also evident. For instance, frequently education and better lifestyle choices are recommended for those who are overweight or obese. The idea being that simply recognizing the need for exercise and a nutritious diet and demonstrating motivation, self-restraint, and a positive attitude again will allow everyone to become a healthy weight. Monumental issues such as poverty, community food deserts, food insecurity, and institutionalized racism are glaringly absent from many articles and books on weight loss, diet, and health in general. To demonstrate these points, I'd like to deconstruct and analyze a brief health article in Harvard Health Publications Online. This is similar to an in-class exercise to demonstrate privilege that I often have students in my Intro to Women's Studies class do. And again, I want to stress before I do this that I'm not suggesting the advice isn't accurate and helpful to those who are able to follow it. The article begins with a discussion of diet. Quote, "A healthy diet is rich in fiber, whole grains, fresh fruits and vegetables, good or unsaturated fats, and omega-3 fatty acids. These dietary components turn down inflammation, which can damage tissue, joints, artery walls, and organs." End of quote. Further, the article advises limiting the intake of processed foods as these can increase blood sugar levels, and quote, "High blood sugar is linked to the development of diabetes, obesity, heart disease, and even dementia." So, the overriding recommendation is to follow the Mediterranean diet because, quote, "There is convincing evidence that it is effective at warding off heart attack, stroke, and premature death. The diet is rich in olive oil, fruits, vegetables, nuts, and fish, low in red meats or processed meats, and includes a moderate amount of cheese and wine." End of quote. So all of this is great information, of course, to anyone who has the means to purchase, store adequately, and prepare the food. I think we can recognize fairly easily that a certain privileged group of people is assumed but not acknowledged to be reading this article. Middle class with the time to read and worry about long-term health and no particular concerns about whether they will have enough money to pay for food through the end of the month. But as the Scholars Strategy Network, which does research to improve policy and strengthen democracy, explains, families living in poverty will purchase foods like high-sugar cereal, potatoes, and processed meats because they're cheaper and easier to store. The Huffington Post, meanwhile, reported a 2013 meta-review of 27 studies in 10 countries, originally published in the British Medical Journal, which showed a very healthy diet, like the one described in the Harvard Health publication review, is approximately $550 more a year than one high in processed foods. As an aside, though, I was disappointed to read the concluding paragraphs of the Huffington Post piece. This is a quote. Hidden health costs like our global obesity epidemic, I'm not sure it is global, but anyway, and the food-related public health issues of heart disease, diabetes, and cancer are certainly not included in the cost of your fast food meal. And with that in mind, $550 doesn't seem like so much money at all. A demonstration of unrecognized privilege, if ever there was one. So, I think it's also necessary to recognize that in a lot of neighborhoods considered economically impoverished, processed foods may be the only option because large supermarket chains don't locate stores in those areas. Public transportation to neighborhoods with large supermarkets is time-consuming and frequently difficult to access. So, back to the Harvard Health Publications article. It goes on to discuss the important role of adopting physical activity, which, quote, can greatly reduce your risk of heart disease, stroke, type 2 diabetes, breast and colon cancer, depression, and falls. It continues that activity improves sleep and even sex, and recommends 150 minutes of moderate intensity exercise weekly, along with strength training 2 to 3 times a week. But as the Scholars Strategy Network points out, in many poor neighborhoods, parks, playgrounds, trails, and free public gyms are not available or safe. Neighborhoods may be crime-ridden, and there may be no nearby indoor places for play or exercise. Ironically, parental efforts to keep kids safe and indoors may increase and encourage sedentary behaviors, such as watching TV and playing video games. So again, in the Harvard Health Publications article, there's an assumption that exercising is an individual choice for adults, and that parents are individually accountable for their own and their children's physical activity. And I would point out that in neither the Harvard nor the SSN article is there a recognition or acknowledgement of people whose bodies move through spaces differently from what's considered the norm. But the SSN article concludes, at least, quote, to effectively prevent and reverse obesity among especially vulnerable poor people, we have to think of the issues in more than just individual terms. We must look for ways to begin to improve the social and physical environments in which low-income people live. Interventions in neighborhoods and community institutions can make a difference, end of quote. And of course, secure and ongoing government funding and commitment are required. One suggestion that the SSN made is initiatives like New York City's Green Carts program with mobile food carts that deliver fresh produce, along with preschool and school-based programs. Of course, programs like these depend on widespread recognition that systemic injustice exists in the first place. Okay, so turning once again to the Harvard Health Publications article, there are 2 final areas addressed: stress reduction and finding a primary care physician. Quote, finding ways to reduce stress is another strategy that can help you stay healthy. given the connection between stress and a variety of disorders. Try meditation, mindfulness, yoga, playing on weekends, and taking vacations. Again, these are wonderful ideas. If someone isn't working on the weekends, as many single mothers in service industries are, or if someone has the money and the wherewithal to take time off work for a vacation. Further, classism and racism and their effect on stress aren't even mentioned. In her excellent February 2017 TED Talk, How Racism Harms Pregnant Women and What Can Help, the doula, writer, activist, and founder of Radical Doula blog, Miriam Soya Perez, discusses how racism and the long-term stress it produces harm the body, and specifically the health of pregnant women. She points out that there is, quote, a growing body of research showing that people who experience more discrimination are more likely to have poor health. Even the threat of discrimination, like worrying you might be stopped by police while driving your car, can have a negative impact on your health. The more marginalized groups in our society experience more discrimination and more impacts on their health. Perez explains, if we take a look at the statistics about the rates of illness during pregnancy and childbirth, we see clearly the pattern. African American women in particular have an entirely different experience than white women when it comes to whether their babies are born healthy. In certain parts of the country, particularly the Deep South, the rates of mother and infant death for Black women actually approximate those rates in sub-Saharan Africa. In those same communities, the rates for white women are near zero. She continues that even nationally, Black women are 4 times more likely to die during pregnancy and childbirth than white women, and twice as likely for their infants to die before the first year of life than white infants. And then she brings up a very interesting point. She says that when she explains these distressing statistics to people, I'm usually met with an assumption that it's about either poverty or lack of access to care. But it turns out neither of these things tell the whole story. Even middle-class Black women still have much worse outcomes than their middle-class white counterparts. Even women of color who receive the recommended prenatal care still suffer from these high rates. And so we come back to the path from discrimination to stress to poor health, and it begins to paint a picture that many people of color know to be true. Racism is actually making us sick. And this racism extends to treatment by medical professionals, according to Dana Bowen Matthew in her 2015 book, Just Medicine, A Cure for Racial Inequality in American Healthcare. This racism may make problematic the seemingly simple Harvard Health publication's advice to, quote, establish a good relationship with a primary care physician. Matthew states that annually, quote, unconscious racism harms patient health, cuts short patient lives, increases healthcare costs, and diminishes healthcare quality. She explains that a large National Cancer Institute study showed that when Black and white patients received similar treatments for similar stages of cancer, they had similar survival rates. But minority patients are generally diagnosed at later stages of cancer progression. She also points to similar disparities in terms of heart disease, renal disease, pain control, childhood asthma care, and mental health care. And she very carefully and persuasively explains that the bias and racism demonstrated in medical care are generally unconscious, not purposeful, which in many ways, of course, makes it more difficult to address. And this same kind of bias may exist in the approach to care of various groups of either American-born or immigrants of non-white European descent. A website called EuroMedInfo is designed to assist nurses with cross-cultural care and thoroughly explains different views of and beliefs about illness and its management in different cultures. It's quite strong in its the way it does that, in fact. But while the site's laudable intention is to offer ways to include patients in the development of treatment options, there are certain biases embedded in even the language that's used. For instance, one sentence reads, "Cultural differences affect patients' attitudes about medical care and their ability to understand, manage, and cope with the course of an illness, the meaning of a diagnosis, and the consequences of medical treatment." So what's being referred to explicitly here, of course, is how patients respond to the health practitioner's approach and how their attitudes and beliefs may differ from the practitioners. But the implication is that a different way of thinking means a diminished ability to understand the correct approach, which is the health practitioners. There's no recognition that patients' different understanding might be just fine, as that is, in fact, the truth of their experience. A similar implication about the correctness of the practitioner's views is communicated by another statement that, quote, "A patient who is embedded in the original culture may not have much contact with the predominant cultural group, the one that's been in the United States longer, and may present a greater challenge in patient teaching." So again, the teaching involves the communication of a biomedical model and understanding by the practitioner, who's considered to be the expert who should provide guidance to the patient's understanding and views. So, what's my intended takeaway message? You might be asking at this point. Personally, I like to think of the feminist author and social activist Bell Hooks's specific use of the term enlightened witness, which she uses in the documentary film Bell Hooks: Cultural Criticism and Transformation. The film specifically discusses media and its power to privilege certain people's stories and experiences over others, but I think it's relevant here too. Hooks explains that the term enlightened witness speaks to our ability to evaluate representations. It, quote, "means we are able to be critically vigilant about both what is being told to us and how we respond to what is being told," end of quote. It involves a sense of agency in our lives as well as critical thinking. And these allow us to, quote, "both resist certain kinds of conservatizing representation and at the same time create new and exciting representations." So, ultimately, I believe these kinds of new representations can inspire new ways of thinking about solutions involving real-world social change and justice in terms of healthier and more inclusive communities where varied lived experiences and ways of being are not only continually recognized, but valued and reimagined. Thank you. Any questions? Comments? Disagreements? Well, thank you. And again, I hope I didn't come across as too critical of certain kinds of phrases that may be used lovingly in obituaries. I was a little nervous about that. And I also don't want to criticize anyone who feels that those kinds of fighting metaphors are useful for them personally in their experience of illness. I just wanted to point out that sometimes it can be a kind of dominant idea that is expected of people. Yes.
What do you think the implications of those kind of like battling messages are for people who are entering hospice care or like palliative care?
I guess it would depend on the individual person, but I mean, I think it could be a way of, if people are going into a stage where they're kind of accepting their illness and realizing, I have a certain time left and I want to spend my time in this way, it could be invasive in a sense. Again, I wouldn't want to criticize anyone who felt that that was helpful to them. Does that answer your question at all, or do you have?
It could even be looked at like on a societal level, even with like people who are choosing to die at home. Interesting.
Right, and also, also the whole positive attitude thing. What if you don't feel positive? What if you're feeling in pain and you want that that pain to be acknowledged? I have heard people say, I don't have a terminal illness, but right now I'm suffering, and people keep telling me, well, you're going to get better, it's going to be fine, but I want to acknowledge that pain I'm feeling right now. I'm suffering, and by telling me that, it kind of denies the story I want to tell right now. But, that's a great question. Thank you.
Yeah, I just got through battling breast cancer treatment,
Mhm.
and I would agree with you that that's overdone,
Mhm.
and that you can feel really resentful when you just need to talk to someone and have some comfort for the level of pain and
Mhm.
whatever that you're experiencing at the time.
Mhm.
You can't acknowledge that when everybody's saying, oh, you're wonderful, you're doing great.
Mhm.
You need to stay strong here. So yeah, that defeats being able to communicate your needs. I would
Yeah.
agree with that.
Yeah, and I think you're expressing that very nicely, and in a sense, it's the same feeling that I think Audre Lorde was having. I'm expected to present myself in a particular way and have certain attitudes, and that's not what I'm feeling right now. And it's making me angry. Yeah.
Yeah, there's a lot of pressure to take care of everybody around you.
Mhm.
And the caregivers have a tough time. And I'd be the first one to admit that.
Mhm.
But the person that is battling
Mhm.
illness needs to have care.
Right.
Needs to feel as though they're not responsible for taking care of everybody around them.
Right. It's almost as if you become the educator because you're the one
Who
who,
you are, yes.
yeah, and sometimes you don't feel like doing that.
Yes, exactly.
No, great, thank you. Yeah, yes, Caroline.
So maybe as far as like the enlightened witness and like using the media to tell these stories better, what do you think of like the use of comedy in that? Because I was listening to a story on NPR, they're talking about how comedians now are using like these comedy to talk about tragic experiences or disability in a way that's not doesn't fall into the tragic narrative.
Mm-hmm.
And I don't know, do you think that can help people feel more comfortable around people who have disabilities or who are sick, so those people don't feel they have to put, it is their job to make others feel comfortable?
Right, yes, comedy, of course, comedy is interesting because it can either reinforce the status quo and existing power structures, or it can disrupt them. And I think you're talking about disrupting them and making people think about things in a different way instead of just making assumptions, just instead deconstruct what's going on, analyze it a little bit more. Yes, I think there are some great comedians out there. For example, I really like Jerry Jewell, and she has cerebral palsy, and she brings that in, and she makes people feel kind of uncomfortable, and then she makes them laugh and makes them rethink her as a person. She makes them rethink what cerebral palsy means, what disability means in the world, you know. So yeah, great idea, great comment.
I think a sense of humor is very important to get through difficult times.
Mm-hmm.
If you can't keep a sense of humor, you're going to be in trouble.
Right, and who was it who, was it Linus Pauling who talked about when he was very ill once, he watched a lot of comedy movies, and it's probably not Linus Pauling, but it was somebody, and it made him feel much better, and it was really important, so, yeah. Did some, yes?
I was just thinking how difficult it is for people to know what to pursue as far as healthcare, because not too long ago, I know that the whole issue of taking supplements was very controversial, and now you have all these health food stores,
Mm-hmm.
at least for a certain segment of the population that's available. And then the whole issue about so-called Eastern medicine, oh, you don't want to use that because what we do is better for you. Now you have on the TV, every commercial is about some pill or something.
Mm-hmm.
Pharmaceutical campaign is unbelievable. So when you're bombarded with these kinds of messages, it's really hard sometimes to be strong
Mm-hmm.
and say, no, I want to do A, B, and C and leave me alone.
Right. And the blogger I mentioned, Jeannie Sather, she was very much for having that right to make your own decisions, and to be, that she felt that she was the expert in terms of her health and her body, not her doctors. And so often we're kind of guided into doing something that experts believe is the way to do things, but yes.
That's also true with illness. When you have lots of people telling you, you will just do this, and you just take that, you will get better. And that's tough to do.
Right. Yeah. Anyway, I think the next presenters are coming in, so thank you very much. And if you have other questions, I'll be happy to answer them.